Each speaker will speak for 4 minutes each, and it'll be a for and an against, a for and an against, each for 4 minutes. And then between the two groups, they will decide who is going to do the rebuttal, and they can speak for 3 minutes. So self-testing, as you know, is one of the methods that can be used to increase the testing services and to reach those people who may not come forward for self-testing in HIV otherwise. Self-testing is not a new phenomenon. It's something that's been used for a long time now. People do self-testing to diagnose pregnancy. It's done on the urine. People use self-testing for COVID-19, which was nasal swabs. A lot of people were self-testing for that. Self-testing is also used for finding out how much your blood sugars are and to keep your blood sugars under control. So here we are talking about self-testing in HIV, and I will call the first speaker, Dr. Venkatesh Chakrapani, and he is going to speak for the topic of self-testing. Over to you, Dr. Venkatesh.
Thank you. Good afternoon, everyone. Okay, so yeah. Okay, yeah. So for HIV self-testing, I was thinking like whether we are talking about like for HIV testing in the public health system or self-testing in general, but I would assume like maybe both. One is the HIV self-test kits are not actually currently available widely in India, even for like studies like DDT reports from like Thailand and other countries. But even otherwise, like I think the main point, the number one point which I would see is it's assigned options for people. So it's like autonomy. So if I can be provided with various options of HIV testing, then I can choose among them. So so that is the main value, like the autonomy of the people. So from that point, like I would like to present. Second, in terms of the cost, if you look at the cost, even after importing the HIV self-test kits from say Thailand, it is only like about like 150 rupees to 300 rupees. There are two types of at least HIV test kits. One is the blood-based HIV test. You just like using a lancet, you prick, and then the patient can, not the patient, the person can test themselves. And the other is the oral one, like just you swab and then you can test. So both tests have actually been tested. So I just like to like cite some like findings from one study in which I was involved. It was done by PATH. So PATH, right? Yeah. That's called the STAR project. Is that correct? Right? PATH, which? Yeah, that's right. Yeah. Sometimes they get confused by the NGO. So it's called STAR 3 initiative, in which NACO was also involved. There are 5 authors from NACO in this published paper, because some of the concerns were about like whether there is no pre-test counseling, no post-test counseling, but in this study, like they provided like pre-test education and also like reference to videos, and post-test counseling was available like for people like over the phone, and they were actually connected with the services. The linkage percentage for like confirmatory test with ICTCs is like I think more than 80%, and then the linkage to the AIT services for people who are like positive was like 85%, which is comparable with the ICTC. So the concerns about the people may not be linked to the AIT services, so those were like actually abated by the findings. Another is about the perceived social norms, whether the people will like think about like say committing like some harms to themselves. So in this study, in which like there are 9,000 people were involved, there was only one person who reported that suicidal tendencies, and the person was immediately like referred to like local psychiatric counselor and were provided like counseling. Also, even the perceived social harms, because people may not have access to post-test counseling immediately, so that was also abated by this study. Yeah, I think mostly like the cost effectiveness, like, so even if you expand that in the government program, then basically because we have a variety of options, you can have it as a facility-based self-testing, you can distribute that to the NGOs and CBOs, and there can be secondary distribution through the peers. So all these are like advantage or innovation in the various channels by which we can actually like distribute self-testing. So basically, like why we are also thinking about increasing the options of HIV testing, because at the public health level it's also about the 95, 95, 95, right? The first 95. The first 95 still we are like about 82%. We have to achieve the 95%. For that, HIV self-testing is one of the options which are available. Well, as the time is okay. Time wise. I'm not sure. Okay.
Thank you, Dr. Venkatesh. I now request Dr. Hari Krishna, and he will speak against the topic that self-testing is not necessary.
Slide start.
Meanwhile, before we start, Dr. Venkatesh has said that NACO has given a 9,000 people trial. Yesterday we were discussing the topic by Dr. Das from NACO, and he was strongly discouraging that they are not going to support this program because there are a lot of logistical issues, there is a lot of data management issue. So let us not take that point into consideration that NACO is not going to support this in the near future. And the 95 part, he was talking about the first 95 part. There is a slide of mine which shows that self-testing, most of the times they are underrated, underreported. Most of the people, they don't come to the center where they display themselves that they are positive. So this 95 can never be possible that once they get the test done, either they go into hibernation or they commit suicide. So catching them is very difficult, and achieving that 95, first 95 through self-kits is nearly impossible. The second part we was talking about is the autonomy. I have a slide for that as well. Risk of personal autonomy. So in COVID times we were seeing that when you have to travel and each company asks that you get your COVID test done. So if it is so easily available, then we will be pushed to get our HIV test also get done from the IT companies to the healthcare sectors. And this will give a lot of confusion again, that whom we have to get it tested and whom we don't need to get it tested. So it is definitely a breach of privacy of an individual or an institution that we should get it done so liberally. So my advocacy of this test done is not favorable towards getting the self-testing done. These are the 3 points he was talking about. And in general, if you want to see, the test itself has a lot of issues. So patient doesn't know how to get the test done. See, when we are during the COVID days, we were seeing that patient will put the swab in the nose. If it is painful, he don't push it too deep. Then he will put it that my test is negative. So specimen collection itself is wrong when we are going for a self-testing until patient knows how to get the test done. Then the buffering is a secondary issue. So he is not a technically trained person, and there is no data that there is no videos kind of thing that are available now. Whatever he thinks, whatever he reads, he realizes it. The third point is interpreting the data, false negative data, false positive data, because sample itself is wrong. So he can't interpret the data. So these are the few points, and rest of the things we'll discuss again. Then the sensitivity of the test. 93% is sensitivity of the self-testing versus 99% in the healthcare sector testing. So definitely the test itself has lesser sensitivity values historically. Then the false negative results. So patient will think that he has done the test wrongly, or if he will be in a window period, that is a major concern of this test. Today he will have an unprotected sex, tomorrow morning just like taking eye pill, he'll go and get tested and he'll come negative. Then he will display to the world that I had an unprotected sex but still I am negative. So he will keep having that in a stigma that he is negative. Even if he is positive also, through that the contamination of last night, he'll keep throwing it furthermore with the false belief. And he will have that false assurance also that he don't get the infection because he is not tested already and which is negative. And he'll keep showing that, keep saying that I am negative, I am negative. So that is the bigger crime. Then the implications of low sensitivity, increased risk of false negative, delays in diagnosis. Say, for example, if he comes false negative, he will never bother that do I come positive again. So he don't get tested again. So he'll be roaming around. After 2 years, he will come with a OIR in some other complication. Then he will say, tell that I have tested which was negative. Now how did I come positive? So he keeps denying that I am negative, I am negative. The other major concern is that patients whom I have seen 15-20 years back have an unprotected sex one night, next day morning they realize that they may get positive. And for next 20 years, every week they keep testing. Every week they keep going to a doctor. Ultimately they land up at a psychiatrist or die by suicide. Yeah.
Thank you, Dr. Hari Krishna. Taksa Patel will again speak for self-testing.
Thank you, ma'am. First, we all are, one word I really like, health in your hand. And now, patient literacy and awareness is a very much important area. So, about the self-testing, if you will say like, if there is some of the systematic gap, because at present in the NACO system, there is the self-testing is not part of the system. So that the reason, the data capture or referral linkage or reporting mechanism, it's not in a systematically any organic reporting mechanism. But HIV program is much more mature. It's not new like COVID when we all of a sudden happen in our life. But HIV program is a much mature, even the infrastructure is there. Community-based response is very strong. Even we have a lot of new introduction in the testing facility. When we started about CBS testings, community-based screening, there was a major challenges on initial stage. But now the CBS is at the ground and near to community and even out of the service setup. So it is very easy to access anyone in the community accessibility. And even their village or in their home or even their work site, the community is going and providing the services of CBS facility. Index testing is also now very much taking fast track. So this is all are helping us to reach first 95. So this is one of the service package add value to reach our first 95 goal. The thing we build more about like community awareness, community education, some of the IC material, video facilities, even now so much of virtual facilities like virtual IC material, this all give package of service with the self-testing. I am giving one example of Moderators when we are interacting in a virtual intervention. There was one of the community member who was very worried about to go to ICTC center because of their well-known family, even that he is from, he have their partner in MSM. So when he visited to Mumbai, their Humsafar office, within 10 minutes he found his test is a negative. So that mental stress is we will minimize and reduce because of peer-to-peer approach and peer-to-peer support. And the thing is majorly about linkage loss. We will manage that if this self-testing is in a system, part of the system. So this is the major things we learn. And Humsafar shared with some data, like 1100 community members were part of the self-testing, and 700 plus community members are accepted that self-testing is very helpful for them. So of course, this is small data as compared to our country service setup, but such practice we will start pilot or initiate. So this will be more helpful to scale up the service setup and provide more effective service at the community level. There is one more thing I want to add here. Of course, when any one HIV test is not easy going, if it is in 1998 or it is on today, because that's mental trauma to wait for their HIV test report is not easy for anyone. So it's very short time in within system or within like CBO office. If that it will be part of that setup, it's easy that in 10 minutes, 15 minutes, the person will give the result, and if that person is negative, that prevention message will give more strong to remain that person will negative, but if the person will become positive, so linkage through CBO setup or private setup is easy to capture, so that person will immediate link in the any service cascade, enroll in the ART center, and the access of treatment will be faster. So that's it from my side, and I'm more discussing about the community perspective. So hope this will be integrate in our more option for community members for their testing facility. Thank you.
Thank you, Taksa. Dr. Vinay will again now speak against the topic.
Yeah. First of all, the thing is, if I ask you a question, social media, for or against, it doesn't make any sense. There has to be a statement for which you speak something or against something. So self-test, for or against. I think the statement should have been something like, we assume that it is that will self-testing help, promote, prevent, eliminate HIV or something for or against, then it could have been a fight.
I'm sorry. The topic is self-test. Should self-testing in HIV be included in the national guidelines?
No, it is no. The subject is self-testing.
Yeah.
Second thing, I was wondering whether Daksha was talking for or against, because she almost said that in a community, self-testing is what I do in my own privacy. Okay, and she's saying that including in the self-testing, that means you sit in a counseling clinic, instead of someone drawing your blood, you do a self-test. So that's not self-testing. So she is talking for against the motion that you include it into a program kind of a thing. But anyway, the thing is, when we are talking about 95, 95, 95, we have to look at, of course, any new approach as a cafeteria approach is welcome. So technologically, if you say atomic fission or fusion, as a technology it is good. The point is how much it is going to help, how much it is going to defect, or how much it is going to be cost effective. Because we have reached 83%, 84%, we have got a gap of 95, about 12%. So adding an option is a good thing, but how much cost effective is going to be? Who is going to use it? How many people are going to use it? And then how much addition of positive people it is going to make to the program when we promote something as a cost will have to be taken into account. And we have seen, except for the smallpox vaccination, there is not a single technological solution which has sorted out the social problem. There are a lot of sociological problems that come with that, which Hari has said, like the stress that a person would feel, the isolation a person may feel, and we have seen people who, and currently also when self-testing is not available in the form of oral kits, we have almost all of us in this hall have seen people who have done something or not done something or felt that they have done something, gone to a lab, got themselves tested and come back with the report and with a stress and HIV phobia and STD phobia, etc., etc. So people are anyway self-testing. A lot of people are self-testing, but they are coming back with a lot of tension. So basically, given a choice, that is what happened, because there was some program about self-testing going on in Pune, and my center, Prayas, was enrolled in that program. And that was exactly the part of system kind of a thing, that you pick up from somewhere, get your self-test done, talk to someone, show the report to someone, then someone would talk to that. When they came to our clinic to pick up this thing, and when the counselor was explaining to them that this test is done like that, and the option is that you get a test done here, and we will give you test reports in 15 minutes after counseling. So people preferred, not a single person picked up a self-test. Everybody preferred a actual lab test because it was a supported test. So given a choice, people would definitely like to have a supported test rather than a self-test without any support. So when you are saying that there will have to be a lot of support, explaining that in the community center, etc., I think we are going in for an advantage would be there, but it's a marginal advantage of self-testing. Then a last thing I would like to say is that HIV testing is not just to find out the remaining 95% who don't know about their status. HIV screening is basically for keeping people who are negative also negative. So people, when they get tested, people who are using or are having unprotected contacts or something like that, if they test and say that, okay, today I am negative, no one is going to tell them the options about prevention. Who is going to talk to them about condoms? Who is going to talk to them about PrEP? Who is going to talk to about PEP? Who is going to talk to them about U is equal to U, etc., etc. So when you say that there is one prevention strategy which works for someone, we are eliminating the options of all others information, and you are relying on technology and non-personal kind of communication. I think when we are really wanting to reach out to those 12% or 13%, whom we want to catch, it's likely to be a marginal benefit, but as a public health program, we'll have to look at the cost effectiveness, number of kits, the number of companies, the standard of the kits, the sensitivity, etc. of the kits, where they will get it. Someone uses some kind of a duplicate kit, gets a test which is positive or negative, we don't know. So I think it's a thing to be done with caution in public health program. If there are good kits, if there are good support systems, one can of course choose to get their tested or tests done anywhere and anywhere. Thank you.
Would one of you like to give a rebuttal to that? You have 3 minutes.
Okay, I'm back, but 3 minutes is short to answer all of those questions. One is about, I'll start with of course, the possibility of like forced testing, because even in my qualitative study, the HITRAs, they were worried that the HITRA group, they may ask them to test before them to find out whether they are positive or negative. So that's a real concern that there can be forced testing. But this forced testing is not limited only to HIV self-test, meaning self-testing. They can just ask them to get tested in a lab, right? And then ask them to show their results. So that is one, but of course we need to educate the people about one should not be doing like a coerced testing, forced testing, so that can and creating awareness about the legal implications. So that is one. Second is, of course, WHO has incorporated self-testing in the consolidated HIV testing guidelines. So they have done it after a quite elaborate, say, systematic review, meta-analysis, and also in consultation with the experts. They also have pre-approved self-test kits which are like WHO pre-approved. So that actually like maybe eliminate some fears in relation to the quality of self-test kits. I think nowadays, like even about the window period, like because it also depends upon the sensitivity, meaning the generation of the test. So nowadays, you know, like third generation, it can also become like IgM rather than only IgG. And fourth generation can also like pick up like P24 antigen. So self-test kits can also like in the future, like I guess like it will be evolving in such a way that you can get like fourth generation self-test kits so that it can pick up the infection at a very early stage, so we can avoid the false negative kind of like impression like only with the self-testing, because that's a real concern for even like the lab tests which are done outside, right? Okay, and another is about self-testing doesn't mean they have to do in a, like they have to lock themselves in a room. So there is also actually like the concept of assisted self-testing and unassisted self-testing. So assisted self-testing is the one like where they can come to the facility and they can, under the guidance of say a counselor or somebody up here, they can actually do it. So it is not that like we are going to just going to be impersonal in relation to attaining self-testing. I think in relation to the I will again refer to the PATH study. In the PATH study, among the 9,000 people, 48% were first-time tested, which means they would never been tested if the attained self-test kits were not available to them. In another study called Save Jindagi from JHU, they identified that among the 4,000 plus people, like 6% were HIV positive. So that they were primarily from key populations. In the PATH study, because a lot of the people are actually from general population, and there was a marginal benefit. Of course, like I will admit that only 0.4%. But if you do that in key populations, which is at least like focusing on key population, the yield of HIV can be very much higher. And the reference to the confirmatory testing was also very good. And I already told the statistics. And the reference to the ART centers was also very good, comparable to that of the ICTC centers. I think one other issue like they pointed out about the risk of harm, like suicidal. I already pointed out from the 9,000 people study, like the PATH study, only one person had suicidal tendencies, and the person was actually connected immediately with the professional psychiatric counselor. I think mostly I have covered my points. Okay, but anyway, so because even WHO now, they don't talk about pre-test counseling, they talk about pre-test education. So even in the self-test kits, DGCA have already told like it should be like detailed instructions should be available, and there should be, even in the past study, they have provided links to the videos. So they can look at the videos online, like, and then they know like how exactly to do. Another point which I missed is there was one study which actually tested like the concordance between a professional person reading the self-test kit results and only the person interprets the test results. They have shown like very good concordance between these two, like a professional person reading the HIV test result, the self-test results, and the person themselves reading it. That actually shows like that of course highlights that we need to provide adequate information to the people so that they can correctly interpret the self-test results. I think those are the, okay, finally closing with the programmatic implication. So regarding the cost effectiveness, so we saw that like 150 rupees or 300 rupees, but if it is going to be bulk purchase, and if it is going to be a long-term benefit, if you look at like it is actually going to decrease the congestion of people who are waiting for HIV testing ICTCs. And also like in TA program, every 6 months they have to undergo HIV testing. But already there is community-based testing which is there. So this is the additional option which we can give for people, at least in the, for example, TA program, they can test themselves. As you know, like in the TA program, the HIV conversion is very, very less because they are following like the same people. So the seropositivity is very less. But this kind of like, but involving like, that is why another point I want to add is moving away from the hotspots. Like if you also like which one you mentioned as well, because we can able to provide information and we can able to courier the self-test, or we can provide information where and how they can get the self-test kits. We can able to reach people who are not currently being reached by the TA program. Thank you very much.
So Dr. Hari will rebut. 3 minutes.
There are 2-3 points I can rebut. The costing part, 150 rupees for key population. It is not one-time go. So whenever they have doubt, they have to keep doing that. So it is not one-time investment. So it is a recurring investment which matters. The second point, what Dr. Venkatesh was talking about, is the 900 people in the trial. So this is being promoted as morning after test. So it is very difficult for the subjects to keep into the trial that when they are going to get have an intercourse and when they are going to get test. It is very dynamic situation, unlike you are taking somebody into consideration like a test, drug trial kind of thing. So it is very dynamic whom we should take into the trial, and morning after test, when should they get it done, how many times they should get it done to really prove them as a constant negative. So there is no constant negative test by self-testing methodologies. The other point what I have to mention is that 700 workers whom they have tested proven negative. Right, so now they get that false confidence that okay, somebody has come and tested me at home saying that I am negative. So I am negative, and this negative, works good or stands good for lifetime. Like COVID, somebody comes and gets the test done saying that okay, I am negative today, so I am negative for the entire epidemic season. So this is a dynamic situation that one time tested negative cannot be tested negative forever, or one time comes negative is taken into consideration forever. These are the 2-3 points which we need to take it into consideration. I'll quickly wind up because we have discussed so many things. Social stigma, negative, lesser sensitivity of the test itself, and wrong methodologies, and poor technique methods, and cold chain management, cost effectiveness. So there are multiple reasons to not to advocate this as a standard method of testing in a community. This may have future if we have a stringent rules or stringent procedures to follow. So there is long way to go to make this as a standard of practice or point of care testing, or for somebody who want to keep testing like pregnancy pills. So I'll close this with a simple remark I was writing about, that don't ever ride in a shortcut, because this is kind of trying a shortcut. Because shortcut will always attract you to chalan katega. And here, chalan is somebody's life. So it is somebody's mental, social, physical and economical stress. So don't let our patients to have this chalan katna chahiye. So with that, I close the remarks and open for discussion.
Thank you very much, Dr. Hari. Can we just have a little voting here? We'll just see. Okay. So fine. You have heard them. 2 of them have spoken for HIV testing to be included in the national guidelines. 2 of them have gone against it. Are there any comments from the audience? Sure. Dr. Elandi?
So in 1902, George Bernard Shaw wrote a beautiful play called The Doctor's Dilemma. And one of the protagonists in that play says, every profession is a conspiracy against the late.
I need to make just a comment. I was just hearing that. I think none of the points were all valid for both sides. I personally feel today, 2025. Today we are talking about, in HIV prevention, about PrEP. Right? It's not available in India, the long-acting drug, but it's going to be available anytime soon. Already, Indian companies have started manufacturing capivacirin, the NACO raining over it. So if you want to have all those interventions, unless you know your HIV status, you can't keep on going to your facility to do this. At least for that purpose, self-testing will play a very huge role, otherwise it will not be implemented. And also we have been talking about, it's a need from, side. We have to look at not what had happened or, stigma is there, it's continuing to be there. Just look at for a moment, we did a lot of self-testing for COVID. If COVID would have been transmitted through sexually, do you think all those people would have done all those self-testing? So I think we have to plug in what really the root cause and work on that individual. Because today self-testing is a very important technology to find their own kind of HIV. To do some intervention, either linked to treatment, which we all know that good for the individual benefit and as well as usable you. And also now we have got Trump coming up. Lenacapavir is going to be like a vaccine. We are all going to have it, all the healthcare workers. You know, it might be like good Trump even for us. So the way, if you want to do this, I think we have to implement way. But on the other hand, rather than talking on negativism on that tool, how we can find ways to move this path. Thanks.
Any other comments? Yes.
I feel this 12% gap is there to reach that 95. Even if you keep it open, as they say, self-testing, I don't think people are going to come forward and get it tested. These 12% are anyway reluctant. If they have a choice, they are not going to use it. That's what I feel.
Okay. Just like to give a few comments. Yes, sir.
Once again, not against or for the HIV self-testing, but what I feel as a clinician that will miss the chance of other STI screening when it is done in the field versus the healthcare sector. Sexually transmitted other infections would be missed if it is in a non-clinical care sector.
So I would just like to make a...
Glory. Here.
Yes.
Thank you for raising this particular point. I want to point out one practical aspect of testing. A surgeon who is doing surgery pre-operatively, he wants to know about that HIV status. Actually, this is a misleading message to the clinician. If we say HIV negative, he is free, he will do surgery at ease. If we say HIV positive, he will be very restricted. But all HIV positives are positives, but negatives are not negatives. So ideally, every patient, every case must be treated as HIV positive, and prevention must be like that. So there is a big quarrel in many hospitals. In the night time, they say that why you are not doing HIV test in night time? We have to do surgery. We say that you do your surgery to treat it as a HIV positive. Why you press the laboratory to give the report at midnight? It is absolutely not required. And mismessage is lying with every surgical persons. So this message must be clear. Till today, they are in this stigma that negative means we are free. So this is a wrong message to the surgeons and operative peoples. Thank you.
Self-testing will be helpful, especially in a high-risk community group. Sexual abusers, IV drug abusers, where they know that other partner may be positive. So in that group, they can go for self-testing. That is one. And whenever you go to the hospital, nowadays, if I want to get an HIV test done, no. We have to have an informed consent. Only with their consent, they have to get it tested. So they have hesitancy to give the consent for self-testing. So like testing in the lab. And second thing, whenever you're going to have a self-testing, simultaneously you're going to screen for the other partner. By this, the number of incidents of HIV or the new detected cases can be increased. So these are some of the advantages where you're going to have a self-testing.
Exactly that. What we wanted to say is that as a technology, we should be looking at it, promoting it, etc. But during the COVID time, our friend Ganga Kedkar, day to day on TV, was telling us the same thing, that COVID is different because it has not given us time to educate people. In HIV, we have got so much of time now, 40 years, and still people are not educated about condoms. We have to still keep on doing about that. So it takes a huge time for people to learn new things, understand new things. And COVID had not given us time, and that's why there were so many problems. So unless we have proper backups, proper systems, proper ways, and then understand that who is going to do it and how to interpret it, then only this technology is going to work. Otherwise, it can have some bad effects or disastrous effects. So it's a thing to be handled with care, that's all.
So I would like to end by just saying a few things. I'd just like to end by saying a few things about self-testing. We do voluntary counseling and testing. People who perceive themselves to be at risk come to a voluntary testing and counseling center and get tested. You have people who are pregnant, they get tested for HIV. You have people who have TB, they get tested for HIV. You have people who come to the STI clinics, they get tested for HIV. So all these strategies are to actually increase the to find out the number of people living with HIV so that you can broaden your search for them. Similarly, self-testing is also one such strategy. And it is a well-known fact, it's always mentioned, that the last 10 to 12% of people who are still don't know their status, it's because they belong to the most vulnerable section of the community. They cannot put in an appearance into the public domain because they will feel stigmatized and discriminated against, and they feel frightened to come and get tested. But they say that by extending the testing and giving the people autonomy to do their test, we probably will find more patients, more persons who are living with HIV. And like Dr. Venkatesh did mention about the 9,000 patients that they did under the Safe Zindagi study, they had a 6% positivity. And similarly, there was another smaller study done somewhere else where they had 5% positivity. So it seems to show an increased level of positivity in certain communities. The other thing about self-testing is it's not just that you go and take a kit and you do it. There has to be a lot of awareness given about it, about self-testing in the form of videos, in the form of placards, in the form of bills, everywhere using social media, etc. And you don't expect the person to do the test all by himself. He is assisted in every test by either having a person online who will support him, do the pre-test counseling, tell him how to do the test, or you have a video which you use to do the test. And there are two types of tests, the oral test as well as the finger prick test. So it's blood test and a sputum test, an oral test. And it follows the same principles as any other HIV test. It's like a card test. So if you're making a mistake, you won't get any bars on it. And if the control is not showing up, you've done the test wrong. The second thing is that there is post-test counseling, and even though you're saying that you're giving the patient autonomy, you should also remember that it has to be supported with patient responsibility. And that is something which also has to be publicized. That if a patient is doing the test and he's found to be doing it by himself and he's found to be HIV negative, he has come to do the test because he perceives himself to be at risk. And therefore, he should be sent, and at the moment we don't have that, he should be sent to a PrEP clinic so that he can keep himself negative. Either, he has to use a condom consistently, or he can opt for voluntary male medical circumcision, or he can be on PrEP, oral or IM whenever it comes, or whatever it is. But what I'm saying is that it's a strategy that needs to be included in the armamentarium of diagnosing HIV in a country. And it's not simple. The tests are standardized. WHO has a huge gamut of tests, that pre-qualification tests that one has to undergo before that HIV test can be said that you can use this test in your country. And just for the, I'm not being partial here, I'm just telling you facts. And the other thing is that there are 98 countries in the world which are licensed to do self-testing. 62 of them are doing it very actively. If you ask me today, I don't think our country is ready for self-testing. A lot of preparation has to go into it before it can be done. But it's something that we shouldn't look at as completely negative. There are also a lot of studies which have been done which show that suicide doesn't happen if a person is diagnosed to be HIV positive, provided he is adequately counseled and supported before he does the test. There have been about 7 or 8 studies, scientific studies, which have shown that suicide doesn't really happen. And the other thing is that, so in either whether your test is positive or your test is negative, you have to be supported either with, go to an ART center and get the whole gamut of things done, or get PrEP, or how to remain HIV negative. And information has to be provided to everybody before this test can be done. It seems to me that the community of people living with HIV, the key populations, want this testing. So that's where it is at the moment. And at this point in time, I don't think India is ready for self-testing. Having said so much, maybe we could take to voting. And how many of you feel that self-testing is an option? It's a must or it's an option? Can you please raise your hands? Nice and high. Yeah, it's a strategy.
That was not the statement we were debating. Please self-testing is an option. Yes.
Dr. Glory, we are 30 minutes beyond schedule.
Raise of hands. How many of you are for self-testing? Yeah. How many of you are not? Okay, I think it's equal. Thank you very much. Yeah.
Thank you very much.
Conflict. I will declare a conflict of interest that Prayas website says that you can come to our clinic and pick up self-testing kits.
I request Dr. Glory
Thank you so much
to hand over a token of appreciation to our doctors in this session. Dr. Vinay Kulkarni. Dr. Hari Krishna. And Ms. Daksha Patel. Thank you very much. With that, we move on to our next session, which is interactive clinical discussion and case presentations. I would like to call upon our panelists for this session.